Today we are going to be talking about conduct problems. This is the lecture that I both love and dread, in part because I will say things that I probably shouldn't say, and especially this year with everything being recorded, there will now be actual footage of me saying the things I maybe shouldn't say. What I want to just start with before we get into any content is we need to remember that all children and all adolescents will occasionally do things that we consider bad, okay? I don't think there's a child alive out there who has never lied, cheated, hit someone, any of those sorts of things that we would generally consider bad behavior. That does not mean a child who engages in bad behavior is not automatically a child with a conduct problem. And that's really important to keep in mind, that when we're talking about the conduct disorders, we're talking about those extremes, okay? So children who engage in this behavior very regularly, and there's other things underlying it. It's not just normal children who do occasional bad things. These are extreme and frequently engaging in the behavior. So I just want to start with that as a bit of a caveat. Now, what you're going to do is you're going to go watch a feature film. Make some popcorn, get a drink. The movie is The Good Son, and even if you've seen it before, I want you to watch it again, because normally in class I would be having you watch it, and I think even if you've seen it not in just sort of a, you've happened to found it somewhere, or you watched it and you really liked it or you really didn't like it, you probably weren't watching it from a child behavior disorders perspective. And so what I really want you to do is to sit down and really, really watch it and think about it. And one of the things that you're going to find on Blackboard is this. It's a poor photocopy, but it is a photocopy nonetheless. This is the DSM-4 diagnostic criteria. So DSM-4 was the version that came out in, DSM-4. So 1994, which is around, I think this movie came out in the 90s. I can't remember around, but as you watch the movie, keep an eye on this diagnostic criteria, because what you're going to find is that one character in the movie ticks every single box. It's as if the writers were sitting with the diagnostic criteria while developing the character. They probably weren't, but just humor me and do that, okay? So this is up on Blackboard. You can download it. You can print it if you want. It's just a single double-sided page. Again, the diagnostic criteria has shifted a bit. We're now on DSM-5, so there was also DSM-4-TR in the middle, but this is the criteria that would have been in place at the time of this movie. Now, the movie is streaming on the library website, so if you click this link and it doesn't work, you need to go to the MRU library website, search for The Good Son. It's available and streaming on the Criterion On Demand service. So one of the nice things as a result of this shift to alternate delivery and with the pandemic is that the library has a bunch more streaming services than they used to. So I used to actually bring in a physical DVD of this movie to class to show it. But now you can just stream it on your own. Just make sure you're logged in to the library website using your MRU credentials. So if the link doesn't work, you might want to try logging into the library website and then just copying and pasting the link, and it might. But otherwise, there's your step-by-step guide to how to find it. Watch the movie and then come back, and yes, of course, there's a reflection question right after. Okay, here's reflection question number 1 based on the movie you just watched. In the past, some students have told me that this movie is a very effective form of birth control, even though that is not its intended effect. How does knowing that children like Henry exist change your thoughts on either having kids or working with kids in the future, if at all? So take a minute to think about that. And of course, when we do come together for discussion, we will be discussing not just this question, but we will just be discussing Henry and the movie as well. Okay, so you've had a chance to do that. So let's now take a look at the defining features of the conduct disorders from DSM-5. So we're going to start with oppositional defiant disorder, and then we will talk about conduct disorder. Oppositional defiant disorder is a recurrent pattern of stubborn, hostile, disobedient, and defiant behavior. Typically, oppositional defiant disorder will appear by the age of 8. And there's 3 dimensions that we think about and look at when we're talking about ODD. One is negative affect. So these are children who tend to be angry, they tend to be irritable, and again, that's their persistent pattern of behavior. It's not a one-off. So if you have any children in your life or you think back to your own childhood, of course there were times that you were angry. Of course there were times that you were irritable. That wasn't your persistent pattern of behavior, your persistent way of being. It might have been if you had ODD, but I'm assuming that you did not. The second factor that we consider, the second dimension, is defiance. So they are defiant and headstrong, and not in the good way, right? So there's been a lot of chatter over the years about, we should be encouraging children to, pursue what interests them and to speak out, and absolutely we should. And instead of calling a child bossy, talking about their leadership qualities, right? That's one of the things that we're trying to, we don't need children to be perfect little children who follow everything we say. They don't have to be obedient. They can definitely be their own person, but it's about how they express that. So, as an example, a child may be particularly headstrong and have strong opinions about what they want to wear. That is not oppositional defiant disorder on its own, right? So a child who, let's say, refuses, a girl, we'll just use a girl as an example, who refuses to wear pants, only wants to wear skirts and dresses. And parents keep buying the child pants and the child is like, no, I won't wear them. Okay, yeah, they're being headstrong, but that's not indicative of a problem necessarily. If the child takes the pants that the parents buy and lights them on fire, or throws them in the toilet to clog the toilet and make the toilet overflow, and then it's toilet pants, so of course they're not going to wear them. Okay, now we're talking about something else, right? So again, we have to think about sort of what would fit within the normal limits of that's just normal childhood behavior, or that's normal headstrong, opinionated behavior versus what's going to the extreme. Does that kind of make sense? Hope so. Again, I'm not getting feedback from you in the moment. So, and Ian doesn't have to pay attention, right? He's not obligated. So it's all good. Third dimension is hurtful behavior. And so what we often see with children with oppositional defiant disorder is they will be vindictive. So that kind of ties into the example I just gave of the child refusing to wear pants and then setting them on fire, right? Or getting a pair of scissors and cutting them to shreds and then decorating the house with the shreds of the pants that the parents bought. That's, again, not going to be typical behavior for a child. And of course, all 3 of those dimensions are also related to conduct disorder, but oppositional defiant disorder is sort of that step before. Children with oppositional defiant disorder oftentimes have friends, and that's a big difference between children with conduct disorder and children with oppositional defiant disorder, because typically their behavior is directed at authority figures only. So you might remember times in like elementary school or maybe even junior high where a teacher said, okay, put all your stuff away, we're going to have a surprise quiz. And you were like, oh crap, right? But you didn't say oh crap out loud, and even though you knew that you didn't do your homework or you didn't read the thing you were supposed to read and you knew you were totally going to fail this quiz, you dutifully put all your stuff away and just sat there and hung your head and went, oh no. Well, the child with oppositional defiant disorder is like, hey, you didn't say anything about a surprise quiz, I'm not doing it. And you're secretly thinking, you go, right? Like, so as a child, you like the kid with ODD because they're saying what you aren't saying, and they're the one who's getting sent to the principal's office and buying you some time to quickly look at your notes in your desk and then not fail the pop quiz. Teachers are not big fans of children with oppositional defiant disorder. Parents are not big fans of children with oppositional defiant disorder because the child with ODD will be defiant towards authority figures, predominantly, not so much peers. So at this stage, I would say go ahead and grab your textbook. Go to page 274 if you have the 7th edition, 275 if you have the 6th edition, to take a quick peek at the diagnostic criteria. Okay, and part of it, and I'm just going to sort of show it visually, it's just this one blue column. And the reason I'm showing it visually in part is because when we next look at the diagnostic for conduct disorder, you're going to see some differences. But essentially, it's a pattern of angry or irritable mood, argumentative or defiant behavior, or vindictiveness lasting at least 6 months, as evidenced by at least 4 symptoms from any of the following categories, and exhibited during interaction with at least one individual who is not a sibling. So the creators of the DSM are aware that siblings are awful to each other. They just are. So this behavior has to be exhibited against someone who isn't a sibling. So in terms of angry, irritable mood, often loses temper, is often touchy or easily annoyed, is often angry or resentful. Argumentative, defiant behavior, as exhibited by things like arguing with authority figures for children and adolescents with adults, often actively defies or refuses to comply with requests from authority figures or with rules, often deliberately annoys others, and often blames others for his or her mistakes or misbehavior. And in terms of vindictiveness, has been spiteful or vindictive at least twice within the past 6 months. It's also important that this is not, the child does not have other disorders that would better explain this behavior, okay? So that's the gist of oppositional defiant disorder. So teachers aren't particular fans, parents and other adults aren't particular fans. Oops, yeah, it went backwards. What? So now let's get into conduct disorder. That's our heavy hitter, right? And conduct disorder is pretty much what you saw in the movie The Good Son, in Henry's behavior and Henry's overall demeanor. And again, we are going to talk about that when we come together for discussion. So conduct disorder is described as a repetitive and persistent pattern of severely aggressive and antisocial acts that involve inflicting pain on others or interfering with the rights of others through physical and verbal aggression, stealing, or vandalism. Okay? We're looking at sort of 4 dimensions when we're talking about a diagnosis of conduct disorder. One is aggression to people and animals. And so again, we saw that with Henry, right? Let's see, drowned Richard, tried to kill Connie on more than one occasion, and shot a dog. Yeah, okay, that would be, and Ian just went, what? He's now thinking like, okay, do I watch The Good Son on lunch break today? Because it's streaming on the website. So we saw that aggression towards people and animals. Destruction of property or vandalism is the second dimension. Well, yep, throwing those rocks through the abandoned warehouse, well, that wasn't so abandoned, the warehouse windows. Mr. Highway, so causing that massive pile up on the highway. Those would certainly count as destruction of property. Deceitfulness or theft, so things like lying and shoplifting. I would say having Richard's rubber ducky in the shed of horrors would go ahead and qualify for that. And then also serious violations of rules is the fourth dimension, so things like running away, truancy, which is not going to school. We didn't see that level, but we certainly did see a lot of violations of sort of norms and rules. Particularly the one that stands out to me is when Henry goes to the psychologist to talk to her as if he's concerned about Mark, and it's like, wait, what? And I'm also thinking the psychologist should never have sat down with Henry and listened to what Henry had to say. So we do see that as well. So we really see that Henry hits every aspect of the diagnosis pretty well. Okay. And I did say that I was going to flip over to the diagnostic criteria in the textbook, which is what I'm going to do right now. Let me just pull up where it is. So it's table 9.2. And the reason I wanted to show the comparison is, remember oppositional defiant disorder, how small the blue box was? This is conduct disorder. So the full textbook page and a little bit on the next one. So we're talking about something fairly significant. And I say that to emphasize the significance of this. I'm not going to read through the whole diagnostic criteria. I've just given you the 4 dimensions are the big thing. But then there's a bunch of specifiers as well. So it's just, we're talking big here, right? We're talking conduct disorder is a significant disorder. In terms of the age of onset, so one of the things we have to keep in mind is conduct disorder is only diagnosed when a person is younger than the age of 18. So it is a childhood disorder. And childhood onset, so showing these behaviors before the age of 10, tends to be more severe than adolescent onset. So adolescent onset would be after age 10, so 11 to 18. Childhood onset, so it's going to be more severe, more likely to be boys who are diagnosed with it, and adolescent onset is less likely to persist. Okay, so that's slightly positive. That if someone is diagnosed in adolescence with adolescent onset. Now remember, someone could be diagnosed in adolescence with childhood onset because as we look back at their history, we see the onset of the behaviors and the disorder prior to the age of 10. Most children with conduct disorder will not meet a fate like Henry did in the movie, but many will spend time in juvenile detention facilities, possibly in group homes or foster homes. They'll be removed from their family of origin depending on what they've done. And may very well then go on as they get older to develop antisocial personality disorder. But I'm getting ahead of myself a little bit. In terms of the connection between oppositional defiant disorder and conduct disorder, some children with oppositional defiant disorder will develop conduct disorder, but most won't, okay? So about half of the children with conduct disorder will have previously had a diagnosis of oppositional defiant disorder, but only about 25% of children with oppositional defiant disorder go on to a diagnosis of conduct disorder. Okay. Now, I briefly mentioned antisocial personality disorder, and so I want to just speak briefly about that and psychopathic features that we may see in people. So antisocial personality disorder, of course, is a persistent pattern of disregard for and violation of the rights of others. 40% of those with conduct disorder will go on to develop antisocial personality disorder. Okay, so that's something that's pretty big. We're getting close to half, right? 2/5. Antisocial personality disorder is not diagnosed until someone is over the age of 18. And the other thing is that a necessary component of an antisocial personality diagnosis is the presence of a conduct disorder prior to the age of 18. Now, that doesn't mean it has to have been diagnosed, but we would have to, through retrospective reporting, through looking at records, see that that pattern already existed. Okay? When we're talking about psychopathic features, we're talking about patterns of callous, manipulative, deceitful, and remorseless behavior. So one of the things that you might remember from the movie is at one point Mark sees Henry looking in the mirror trying to look sad, and he's asking him what he's doing, and he's like, well, I should be sad at my mother's funeral, shouldn't I? Right? And so it's that moment of like, he doesn't actually feel emotion. He doesn't know what sadness is, but he has to figure out what that looks like so he can play the part properly. Again, with Henry, we definitely saw these psychopathic features, that callousness, the manipulation, remorseless behavior. He didn't feel bad. When he dropped Mr. Highway onto the highway, he was like, whatevs. That was pretty cool. Most people would feel pretty bad about that. Most people wouldn't do that. Let's take a step back. Most people wouldn't do that behavior in the first place, right? The callous and unemotional interpersonal style would then meet the DSM-5 specifier of with limited pro-social emotions. And of course, somebody with limited pro-social emotions is going to have a poor long-term outcome. Somebody who really cannot engage in appropriate emotions and cannot sort of think about other people, that's going to be linked to less positive long-term outcomes. So I want to introduce you to the trajectory of bad acidness. Now, this is something that I pretty much created several years ago when I started teaching this course. I taught a version of this course at the university I was at before coming to MRU. And it just sort of, it's not a real thing. Don't go Google searching for the trajectory of bad acidness. You're not going to find it. But it's a way to sort of keep this in mind and think about it. And so essentially, we started oppositional defiant disorder. And again, remember that 25% of children with oppositional defiant disorder will go on to develop conduct disorder. And then about 40% of people with conduct disorder will go on to develop antisocial personality disorder. And we sort of go in stages like, yeah, you're not so great there. You're definitely a badass here. And oh boy, you are getting the badass crown over here, right? So that's just sort of a way to think about it. This is going to take us to reflection question number 2, which is, well, the trajectory of badassedness is an easier way to remember the progression from ODD, so oppositional defiant disorder, to conduct disorder, to antisocial personality disorder. It is not fully accurate. So please explain one problem with the trajectory. So let's talk about some of the associated characteristics with conduct disorder, particularly conduct, but again, will also apply to oppositional defiant to some extent. We may see some cognitive and verbal deficits. There also might be school and learning problems. And so the reason I'm sort of bringing them both up together is, of course, cognitive and verbal deficits would lead potentially to school and learning problems. If a child, and so this is one of those things where if you think about it, if a child is having trouble at school and maybe they don't know how to ask for help, maybe they have asked for help at home and been shut down, maybe they are just so frustrated that they act out, and acting out, remember, garners them attention. And when children are seeking attention, and again, not in a cognizant way, while we would prefer the children to act in a positive way to get attention, if we give them attention when they're behaving in a less positive way, we're still reinforcing it. So the child who isn't understanding what's happening in school starts to become the class clown because they're getting attention that way. And then it progresses that they're like, okay, the clowning thing isn't working anymore. I'm going to start talking back to teacher. And the teacher responds to that. So they're getting the attention. And what it's really doing is masking the fact that they're having other problems. But now those other problems have developed into a new problem, where now they're exhibiting signs of oppositional defiant disorder and potentially carrying on to conduct disorder. We're also going to see family problems. We're going to see some general family disturbances. So parental mental health problems can definitely be a factor. A family history of antisocial behavior, marital discord. So one of the things that is important to keep in mind is no marriage is perfect, no relationship is perfect, no couple is perfect. People are always going to have conflict from time to time. It's how you manage that conflict. And so do you fight through your children? Do you fight in front of your children? Do you yell and scream and name call? Or do you fight fair? Do you try to hold arguments or big discussions that might be contentious until your children are sleeping at night? Or do you have those discussions during the workday when your child's at school, right? So different things, but if there's a lot of marital discord, that creates an unstable environment, and depending on how the parents are, or the partners are fighting, that could teach a child some ways to behave that we don't really want the child to know. And also limited resources. And so this is not just talking about financial resources. It's not like, do you have the latest and greatest tablet and phone and all the different streaming services, but it's in terms of resources, both in terms of physical resources. So again, we think about Maslow's hierarchy of needs. We think about those basic needs, the safety, security, food, those resources, and then the emotional resources. When you have parents who are working very demanding jobs that are very long hours, they may have very little left to give when they get home. And their child might be acting out, and they just don't, it's not that they don't care, they just don't have it anymore. They just don't have anything left in them. And, you know, I can think just yesterday I was having a conversation with the chair of the psychology department because an issue had come up, not related to classes, but just something that she had forwarded to me. And it had been a few days since she sent me the email, and I was like, listen, I don't have the bandwidth right now to deal with that. Like, there's just too much other stuff going on. And I think we see that with families in terms of resources. Parents just run out of bandwidth. And particularly, I think that's something that's really salient for all of us right now as we're living through this global pandemic. where some days it's just too much. There's just too much happening, and we just can't, right? Like you just hit that wall. And so for a child who's having behavior problems and maybe learning problems and maybe there's marital discord also, the family just has no reason, they have nothing left to give. And that, of course, is a problem because the child obviously has some needs and needs some emotional support. Also, from the perspective of family problems, we can look at some specific disturbances in parenting practices and family functioning that can be associated. So again, these are not causes of conduct disorder. These are associated things that we see happening. And what we're really talking about here is excessive use of harsh discipline, lack of supervision, and lack of emotional support and involvement. So parents who use physical punishment, and especially using physical punishment on a regular basis. Just because you were exposed to physical punishment as a child is not a reason to engage in physical punishment with your child. One of the things that we hope is that from generation to generation, we learn how to do things better, differently, less harmfully, right? But some parents don't, again, they took the prenatal class, they learned don't shake the baby, but they didn't say anything about, don't hit the baby. Well, they did say don't hit the baby, but, if you were beaten with a belt, you might think, well, I'm spanking my kid. That's a step forward, right? I'm not hitting them with a belt, I'm spanking. When ideally we would have neither of those happening for the children, right? So we do want to think about that. We want to think about, is a parent doing that's just what they know how to do because that's how they were raised. So do we need the parents to have some resources? Again, thinking about that lack of emotional support and involvement. So does the parent need some more support? Do they need to be working fewer hours? Do they need some time for themselves before they come home from work so they can kind of hit a reset button? I know for me personally, we used to live close to campus. We used to live in Glamorgan. I used to walk to and from work, and it was this magical time where on my walk home from work, it was like work got left at work, and by the time I walked into the house, I had shifted into, and now I'm home. We don't have those reset buttons anymore. Now that we don't live near campus, and when we're on campus working, and I'm driving to campus, I'm usually sitting in traffic on my way to go pick my child up at the end of the day. That's not a reset button. That's an aggravating button, right? And so I noticed that was a big change for me in terms of how I greeted her at the end of the day from when I used to walk home and have that reset period as opposed to trying to fight with cars for the Glenmore-Crowchild merge and then 14th Street, which is perpetually under construction, to get to her. And I would be like, oh my God, like when is your father coming home and dealing with you? Because I just can't right now. So, and that's with a neurotypical child, and I'm a psychologist, like I should know better, right? So imagine someone who doesn't have that support, those skill sets, that knowledge. They work a really demanding job, they have really long shifts. Maybe they need half an hour of me time before going home and dealing with their children, right? That's something that can happen that might help them get more involved. And then that lack of supervision piece, that ties in as well. When we have children, so a lot of you might remember times when your parents were like a little too present, like you really wish they had backed off. For every child who wishes their parents would back off, there's a child somewhere who's like, I wish my parents were here to actually stop me from doing this really stupid thing, or from engaging in this really risky behavior, or clicking that website and seeing things I really shouldn't be seeing, right? So there's a fine balance there. But that lack of parental involvement is going to lead to things like engaging in risk-taking behavior, possibly stealing, lying, cheating, drug use, reckless other behaviors as well. Okay, peer problems. We are, again, more likely to see that with conduct disorder because these are children who show no remorse. They are not terribly pleasant to be around. Again, oppositional defiant disorder, we're more likely to see children who do have friends because they're typically only acting out against authority figures. Self-esteem deficits, I think that, again, should be fairly self-evident. A child who is acting out in such ways is probably not someone who has a really healthy sense of self-esteem and sense of purpose. And then health-related problems. And again, this comes in from the risky behaviors that we see these children engaging in. So they're at high risk for injury because of risky behavior, for drug overdoses, for substance use in general, and also for sexually transmitted infections because of risky sexual behaviors. Prevalence, gender, and course. So prevalence for oppositional defiant disorder is about 12% of children and adolescents, 13% males, 11% of females. So not too big a difference there. For conduct disorder, 8% of children will have a diagnosis of conduct disorder, 9% of males, 6% of females. So here we see a gender gap. And we do see that boys are more likely to have conduct disorder than girls. So let's explore that gender piece a little bit. Conduct problems are higher in boys. I think that just sort of goes with the territory. I know that certainly if we think about adolescence, we see girls are far more involved in relational aggression, so spreading lies and rumors, sort of excluding someone from a friend group or an activity. Boys, when adolescent guys have a problem with each other, they just fight it out, and then it's good, they give each other a hug and they move on, right? It's one of those things, as a female, I've never fully understood how you could punch someone in the face and then be like, you good, bro? And they're like, yeah, we're good. What? But apparently that happens. So as I was saying, adolescent girls, we see an increase in covert, non-aggressive, antisocial behavior. That's more of, that's not the relational piece. That's the next point coming up. I got ahead of myself there. Girls more likely to use relational aggression. The adolescent girls' increase in covert, non-aggressive, antisocial behavior is more like lying, stealing, shoplifting, running away. So things that don't really, yes, stealing, shoplifting is stealing, and stealing hurts other people, but not in that direct way. It's not a punch in the face. It's stealing mascara. It's still not okay. I am not condoning stealing mascara, but I'm just saying that's different than walking up to a shop owner and punching them in the face and then taking their mascara, right? And then the girls are more likely to use relational aggression, which I already said. In terms of developmental course and pathways, the life course persistent path is when they start early, so they start showing these behaviors early on, and it continues over the course of their life. The adolescent limited path is when the person engages in the behavior only during their adolescent years, their teenage years, and they are less likely to go on to develop antisocial personality disorder. In terms of causes, genetic influence, that is going to be stronger for life course persistent than for adolescent onset. So we know that if someone has other people in their family of origin with conduct problems, that will set them up potentially to be at higher risk for life course persistent. Prenatal factors and birth complications, once again, let's go ahead and blame the mom. But again, these are some of the same things that come up. So the drinking, smoking, risky behaviors during pregnancy, and then any complications that happen during the birthing process. There's so much that we don't know, and so we don't know when someone experiences a birth trauma, so whether it's the umbilical cord being wrapped around their neck, whether it's an awkward delivery position, whether it's a prolonged labor, anytime there is any sort of compromise or damage to oxygen supplies or brain, because remember, kids' heads are pretty soft when they first come out, so depending on what's going on, there can be some trauma to the brain. They should be able to recover from it. That's sort of the way the human body is made, but we could see some consequences later on in life sometimes. Neurobiological factors, we're going to particularly look at the behavioral activation system and the behavioral inhibition system. So again, stopping us from doing things and actually doing things. People with conduct disorder tend to have an overactive behavioral activation system and an underactive behavioral inhibition system. They also tend to have lower autonomic nervous system reactivity. So again, our autonomic nervous system gets involved with, activity and also to some extent with fight or flight because of our sympathetic and parasympathetic nervous systems. If you're slower to react, right? You don't perceive something as a threat or it takes you longer to react to it, you will display different behaviors than someone who actually reacts right away. And so we see a connection there. In terms of social cognitive factors, we see that people with conduct disorder have difficulty attending to, interpreting, and responding to social cues. That's going to be something that is going to be further complicated, of course, in this current generation of children and adolescents who are now experiencing things like being taught class over the internet, not having face-to-face, and even when we're having face-to-face interactions, if we're wearing our masks, can you really read my face? If I can get it on. Can you read my facial expression right now? Am I happy? Am I miserable? Do I want to punch you? You can't tell, right? When I take my mask off, it's a lot easier to read my facial expressions. So that's going to be an interesting thing to see as we go on. But for children with conduct disorders, it's almost as if they're looking at everybody as if everybody is wearing a mask, even when they're not. They aren't recognizing those cues. And so in class, this is one of those times where I would make you really uncomfortable because I would walk right up to someone and be like a close talker, right? So be like right there in front of them, totally infringing on their personal space. Those are things that people don't always recognize. So like if you get too close to someone, you're likely to take a step backwards. And if you can't because you're in a crowded environment, you might say like, hey, you're getting a little too close, or you might put your hand up. Well, they might misinterpret that. Okay, so those are some of the factors that we see there in terms of social cognitive. In terms of family factors, pretty much the same things we discussed earlier in terms of parental involvement or lack thereof, lack of supervision. And then also there's a reciprocal influence on the child's behavior and the parent's behavior. And that's something that I've talked about before. I certainly talked about it with ADHD as well, that when the child is acting out, the parent responds to the child acting out, but then the child further responds to the parent's response, and it keeps going. And so at some point we have to put a stop in, and we have to change the responses. But that's something that we see that goes on, and that's, again, where, hey, therapists are helpful because we can help the family sort of have some reset buttons that they can then make use of. In terms of societal factors, poverty, neighborhood crime, if your peers happen to be gang members, those are all things that are going to contribute to the development of a conduct disorder. The media can play a role as well. In terms of treatment and prevention, early intervention or prevention is really where it's at. The most effective treatment is in a variety of settings, and the family in treatment too. But particularly for young children and for people who are just starting to show signs, if we can get in there with early intervention or prevention, we are doing much better than waiting until the child is already wrapped up in the criminal justice system, the juvenile justice system. And then, of course, we're going to have some ongoing interventions that keep going. So we want to continue to help with as the children get older and as the family continues on this path. So again, remember, families try to stay in balance. So if you have a child who's acting out, we get some strategies. The child stops acting out as much. The family has to reshift its balance. And then if the child starts acting out again, we got to reshift again. So that's something that we have to keep in mind, that we're going to have ongoing intervention. So even if we have good success with early intervention, we're going to want to keep tracking this family over time. Okay, parent management training is something else that we're going to try. So it teaches parents how to help change the child's behavior. We're going to focus on changing the parent and child's interactions and basically using a lot of reinforcement and operant conditioning principles. That's going to be really important. So again, rewarding the positive behaviors, ignoring and working to extinguish the negative behaviors, making as little use of punishment as possible. Punishment doesn't teach new behavior, so if we do use punishment, we have to include teaching new behavior and then reinforcing that new behavior as well. Problem-solving skills training can be helpful for the child or adolescent. It's sort of a cognitive behavioral therapy focus on the cognitive distortions and deficiencies of the child. So trying to change the way the child will respond, instead of being aggressive, what might be a better way of responding, helping them also then try to recognize that the way they're perceiving something might not be the way it was intended, so kind of like checking their perceptions before responding. Multisystemic therapy, which is described on page 307 of your text, table 9.6, is going to be family and community-based treatment for adolescents, and it draws on parent management training, problem-solving skills training, and family intervention. So it's kind of like a mix of everything, and it's really targeted for adolescents to sort of come at it from multiple different angles. And again, as I said earlier, preventative interventions are really what we're hoping for. We've realized that intervening early is best. So even beginning at the preschool level, and you might be thinking like, oh my gosh, are there like preschool kids who are as bad as Henry? Well, no, that takes years to develop to that point. But if we see a child at preschool age who's behaving more aggressively than other children, starting to teach that child how to behave differently could be really important. Working with the child and the parent. And it's important for us to recognize that young children may be aggressive for different reasons. So it might not be that we need to do major psychological intervention. It could be that the child actually needs speech therapy. So I'm thinking in particular about one child who was in my daughter's class at daycare from the time they were babies. And he was one of the slowest to develop language. And so if he wanted a toy from another child, he would just go grab it because he didn't have the words to say it. And inevitably, the other child would oftentimes not give up the toy. So then he would bite them because that was pretty effective. So this particular child bit my child multiple times. And the only way I know this is the teachers are not allowed to tell you who bit your child. They tell you your child was bit, but they don't say who. But my child was very verbal from an early age. So I'd look at her and say, who bit you? And she would tell me who it was. And so the second time he bit her in a short span, I went to the teachers and I'm like, is there a problem here, like, between the two of them? But I know you can't confirm who it was who bit her, but she told me, and they then nodded their head because they weren't allowed to say it, but if I said it, they couldn't really lie. And I was like, I just need to know, is he targeting my child? Or they're like, oh no, it's equal opportunity. Another girl's mother got the second note today as well. I'm like, oh, okay, then it's all good. And not that it was all good that he was biting, but I knew, and the teachers had assured me that they were working on it, the parents were working on it, the parents were embarrassed that this was happening. And once his speech developed, boom, they were fine. And in fact, the very first drop-off play date my daughter ever had was at that child's house because his mom texted me and was like, he really wants to play with her. And I'm like, okay, because he's not biting anymore, right? And my daughter was like, yeah, I'm okay to go play at his house. He doesn't bite me anymore, right? So we have to look at what's underlying the aggression. I don't think he's a child who's going to go on and develop conduct disorder, but I do think that if the parents and the daycare hadn't addressed the biting and figured out what was at the root of it, would he now be a kindergartner who just went up to other kids and punched them if they wouldn't give up the toy? Maybe. But now he has words. And if not, he just bares his teeth and all the kids go running. No, I'm kidding. That's not what happens. Okay. Reflection question number 3. Thinking back to Henry and his family from The Good Son, if you were the psychologist dealing with him and his family, what would you be doing with him or them? So what treatment recommendations would you have, or what would you be doing in therapy? How would you like to see Henry's fate be different than what it was in the movie? And when you're done with that reflection question, we're done with the chapter.